Good evening. My name is Dr. Kishore LT. I'm the Director of Radiology Education and Training, Vijaya Diagnostic Centers. I welcome all of you to today's Vijaya Diagnostic Educational Webinar. These webinars are essentially clinico-radiologic interaction between the clinician and the radiologist. The purpose is to learn from the clinician and share with them the radiologic issues and concerns so that together we improve our knowledge, which eventually improves the patient management. So for today's webinar, we have chosen an interesting topic. It is tumor treatment and pseudo progression. Where are we? And for discussing this topic, we have got two very eminent faculty. First, our today's chief guest is Dr. Senthil Rajappa. He is currently the consultant medical oncologist at Basavatarakam Indo-American Cancer Hospital and Research Center. He has done his DM in medical oncology at famous Kidwai Memorial Institute of Oncology, Bangalore. Subsequently, he was attached to Apollo Chennai and Apollo Vijaya and the Nizam's Institute of Medical Sciences, Hyderabad. He is an excellent teacher and he has received the Best Teacher Award by MGR Medical University, Tamil Nadu. And he has multiple publications and he has written few books. And he is a principal investigator in many national and international clinical trials. And he is also the part of scientific advisory board to many pharmaceutical companies. So, Dr. Senthil, welcome on board. We are honored to have you.
Thank you. Thank you, sir. My pleasure.
And we have our own Dr. Ashish Ghuli. He is the consultant of nuclear medicine in Vijaya Diagnostic Center, Panjagutta. He has done his diploma in nuclear medicine from RMC, Mumbai, and subsequently DNB from Apollo Hospital, Chennai. Subsequent to that, he has done residency in Tata Cancer Hospital, Mumbai, and CMC, Vellore. And he has got extensive training in the therapeutic nuclear medicine. His special interest is in therapeutics and evolution of newer molecules in the nuclear medicine. And he has 12 years of experience in nuclear medicine. Dr. Ashish, welcome.
Thank you, sir.
So today's topic is tumor treatment and pseudo progression. Where are we? Let's say that there is a patient whose diagnosis has been established and staging has been done, and now the treatment starts. It could be surgical treatment, radiation treatment, chemotherapy, or more latest immunotherapy. So when the treatment starts, everybody wishes the clinician and the patient family that everything should go fine and the tumor should come down. But then follow-up is required, and follow-up may show us whatever. We are going to discuss that. So my first question to you, Dr. Senthil, is when you start treatment, how do you follow up these patients? What are the patient's expectations from you? And clinically, and then subsequently, when do you decide he needs radiology? And when you send the patient to radiology, what are your expectations?
Okay, so typically radiographic assessments are made in patients who have metastatic disease. That means you have disease that is evaluable on your scan. That's typically when you do serial radiology assessments to see if patients are getting better. So when we start somebody on treatment, I think it's important to monitor multiple things. It's not only the radiology that matters. I think for me, the most important thing is the clinical improvement that we would like to see. Is your cough better? Is your breathlessness better? Is your pain better? Because that's what gives the patient the first sense of getting better. So that is what we look for every time when that patient comes to us for treatment, whether it's oral therapy or intravenous therapy. The other thing that we are always interested is in side effects of therapy, which is probably a little out of context in this setting, but that's again something that we're very interested, because if you have somebody with advanced disease and your intent of treatment is palliative, then it's very important to make sure that the quality of life is good. So that's something that we always keep in mind. If there are tumor markers to assist in the assessment of the disease, it's not available for all diseases, but at least in certain cancers, we follow up with tumor markers, CA or CA19-9 or CA125. All of these markers are always there to assist. And then the third thing is radiology. So I think this assessment is always triple. And radiology depends upon, where the tumor is, what scans you employ. You may just employ, a CT scan. You may employ an X-ray, because, when we start somebody on lung cancer treatment, when somebody is coming in a month's time, we quickly have an X-ray, because that's an easy, simple way of looking at whether things are getting better or not. You don't need an expensive gadget to, find out what's happening. And then you may ask for MRIs, PET CT scans, and so on and so forth. So I think it's like a triple assessment. How is the patient clinically? How is the radiology? Is it getting better or not? And then what are the tumor markers like? So it's a combination of all of these three that ultimately tell us in which direction the patient is heading towards.
Right. So yeah. So clinical plus biological markers plus finally the radiology. So now I would request Ashish to please go ahead with your presentation.
Okay, sir. Hi, hello everyone. Good afternoon. I am Dr. Ashish Ghuli, working as a consultant nuclear medicine at Vijaya Diagnostic Center at the Panjagutta branch. First of all, I thank Dr. L.T. Kishore sir for giving the kind introduction and giving me this opportunity to be part of this academic webinar. I also welcome Dr. Senthil Rajappa sir on behalf of BBC for this academic session and giving us his precious time from his busy schedule.
Ashish, can you be a little loud, please?
Yeah, okay, sir. Copyright. The sole purpose of the webinar is for learning and by the literature survey on the web. So, without wasting much time, let us begin our today's talk. So, imaging in particular, PET-CT has become an important step in the management of cancer treatment. Also, many novel methods of treatment and options are being introduced in the cancer treatment, like immunotherapy, targeted treatment, anti-angiogenic treatment, etc. in the last past decade, and these are being widely used
Where
in
are the
the
slides?
recent management of the cancer patients. These novel agents produce variable and heterogeneous and atypical response pattern on imaging, which have been studied and which have been published in the recent literature, like hyperprogression, pseudo response, or pseudo progressions. So one of these atypical responses, which we will be discussing today, is pseudo progression, because this is the so these type of atypical responses which we come across in our day-to-day practice.
Ashish, can I just no, interrupt you? Are you showing your slides because we are not able to see the slides?
I am showing, sir. I am on the slide show.
No. Dr. Senthil, can you see his slides?
I can't see.
Yeah, even I can't.
Just a minute. Can you see now, sir?
No.
Shared
What
actually.
do you do now? Ashish, I believe you need to rejoin.
Okay. Can you see now, sir?
No.
Okay, I will rejoin. Sir. Can you see now, sir?
No.
It's already added.
Yeah. Now it is good. Yeah. Go ahead.
Is it changing now?
Yes, it's changing also.
Okay, fine. Thank you, sir. Shall I start again?
Yes, please.
Yes. Uh, so today we will be discussing about tumor treatment and pseudo progression. So imaging in particular, PET-CT has become an important step in the management of cancer treatment. Also, in the past 1 decade or more than that, many novel methods of treatment options are being introduced in the cancer treatment, like immunotherapy, targeted treatment, anti-angiogenic treatment, etc. With introduction of these novel agents, they also produce variable and heterogeneous and atypical responses in the tumor, like hyperprogression, pseudoprogression, and pseudo-response. So one of such atypical responses which we will be discussing today is pseudoprogression. We have chosen this topic because we come across this pattern of tumor response in our daily day-to-day practices. So, what is pseudoprogression? As the name implies, it is initial appearance of increased tumor burden in imaging, which regresses on follow-up, suggesting a response to same therapy. This increase in tumor burden could be because of increase in the size of the tumor. This could be because of appearances of new lesions, or this could be because of increase in the metabolism, as could be seen in any of the metabolic imaging. There are various proposed mechanisms of pseudoproliferation. Some of these are like inflammatory responses, that is infiltration of the T or B cells into the tumors. There could be the necrosis, which is mainly seen after radiation, and there could be increased vascular permeability or there could be increased vascularity. So these variable responses results in an initial apparent increase in the tumor burden rather than true proliferation of the tumor cells. So why this is called as tumor progression? Because these patterns would be categorized as progression according to the normal conventional tumor response criteria. Coming to some of the examples, so this is an baseline study with metastatic lesions or pulmonary nodules on either side. This is a post-treatment study where there is an apparent increase in the size of the lung lesions. However, in follow-up, there is regression in the size of the lung lesions, suggesting the post-treatment scan to be a pseudo-progression, not a true progression of the disease. So another patient with metastatic lung disease, the parenchymal nodules in left lung, along with that, an increased FDG uptake is also seen. In the post-treatment study, there is mild increase in the size of the lung lesions. Also, there is mild increase. There is increase in the FDG uptake in the post-treatment study. But on follow-up study, there is significant regression in the size of the lesions. Also, there is complete disappearance or complete regression in the metabolic activity of the lung lesions, suggesting the post-treatment study to be a pseudo-progression rather than a true progression. Another patient with subcutaneous nodules, or a case of melanoma with subcutaneous nodules in the thigh. In the initial baseline study, there is a subcutaneous nodule is seen in the thigh, but in the post-treatment study, not only there is increase in the size of the initially seen nodule in the baseline study, but also there is appearance of a new lesion. But on the follow-up study, there is significant regression in the size of both the lesions. Yes, or another case of metastatic melanoma with metastatic lymph nodes in the left inguinal regions in the baseline study. In the post-treatment study, there is increase in the size. Also, there is mild increase in metabolic activity of the lesion. Along with that, there is appearance of another sub-centimeter sized FDG lymph node above the existing lymph nodes. But on follow-up study, there is complete regression of these lymph node lesions. It's a case of metastatic breast cancer where a metastatic lesion is seen in one of the dorsal vertebrae. There is mild sclerosis seen on CT with increased FDG uptake on PET-CT on the PET images. But on the post-treatment study, there is an increase in the sclerosis. Also, there is an increase in the SCP values of this bone lesion. But on further follow-up study, there is significant increase in the reparative sclerosis in the bone lesion. Also, there is significant regression in the metabolic activity of the FDG. So this pseudo progression is not only seen in our cross-sectional imaging, but it also can be seen in the conventional bone scan. In this, there is a metastatic disease where is increased uptake is seen in multiple metastatic bone lesions. On the post-treatment study, there is increase in the number as well as intensity of the bone lesions. But on follow-up study, there is further regression in the intensity as well as number of the lesions. So this apparent increase in the intensity and number of lesions could be because of the reparative process or reparative osteoblastic activity in the bone lesions. So, in cancer treatment, the decision to continue or withdraw the ongoing therapy depends upon the response assessment on imaging. Inability to suspect or identify pseudoprogression on imaging could lead to some patients getting deprived of ongoing effective cancer therapy. Hence, it is very essential to accurately characterize and capture these patients with atypical response pattern. If we use our conventional response criteria, then these patients with pseudoprogression will be falsely or wrongly categorized as true progression. Hence, these conventional tumor response criteria need to be modified, or new response criteria have been proposed to accurately identify the patients with pseudoprogression. Hence, these modified response criteria or the other new criteria should be specifically used for the specific patients and for the patients who are undergoing any specific treatment. One of the such modified response criteria is used for patients who are undergoing immunotherapy. So, in this response criteria, the modifications have been made to the conventional criteria like WHO RECIST 1.0 and RECIST 1.1. Out of these different response criteria, iRECIST is more commonly followed response evaluation in the patients with immunotherapy. According to this criteria, if an progression is seen in the patients who are undergoing immunotherapy after the in the post-treatment scan, then these are categorized as unconfirmed progressive disease, that is IUPD, which needs to be confirmed after a repeat scan 4 to 8 weeks later. And in the repeat scan, if there is further progression or there is appearance of new lesions, then this is confirmed to then these are categorized as confirmed progressive disease. Initial progression is pseudo progression if there is regression of the new findings seen in the previous scan, there is partial response, or there is complete response. If the findings remain stable on the follow-up scan, then the term unconfirmed progressive disease should be continued till it is confirmed to be true progression or there is a response on further follow-up imaging. The term unconfirmed progressive disease is given to account for pseudoprogression so that ongoing immunotherapeutic drug is continued and not prematurely withdrawn unless the progressive disease is confirmed on successive imaging or there is clinical deterioration in the patient's condition. Similar modifications have also been done for PET response criteria, and they have laid down criteria called as I persist. In this also, just like I resist, if there is progression is seen in the post-treatment study, then these are categorized as unconfirmed progressive metabolic disease, which needs to be confirmed 4 to 8 weeks after the post-treatment scan. And according to this criteria, if there is complete resolution of FDG uptake, then they are categorized as complete response. If there is more 30% or more decrease in the target metabolic activity, then they are categorized as partial response. If there is 30% or more increase in their metabolic activity, they are categorized progressive disease. And when it doesn't fit of any of these criteria, then they are categorized as stable disease. Coming to some of the examples, this is the same patient which I have shown previously. So in the post-treatment study where there is increase in uptake of the left inguinal lymph node and appearance of the new lesion in the left inguinal region, then at this stage it is categorized as unconfirmed progressive metabolic disease. But on follow-up study, there is complete regression and in the disease process, suggesting it to be a pseudo progression, and there is complete response. Patients with melanoma with a subcutaneous nodule in the left thigh at the baseline study. After treatment, there is increase in the number of lesion. Also, there is identification of a new mediastinal lymph node. But on the follow, at this stage, it is categorized as unconfirmed progressive metabolic disease. But on the follow-up study, there is increase in the size, number, as well as metabolic activity of the nodules and the mediastinal lymph nodes, and it is a confirmed progressive metabolic disease. A case of metastatic lung cancer with a primary lesion in the left lung and with metastatic liver lesions. On the post-treatment studies, there is increase in the number and metabolic activity of the liver lesion, also in the primary site in the left lung. But in the follow-up study, there is regression in the number of liver lesions and FDG uptake with a stable disease in left lung. This is categorized as a partial metabolic response. In this case, the lesion is seen in the left lung, which appears to be stable in size and as well as metabolic activity on the post-treatment study. So it is categorized as stable disease. Another case with the metastatic alveolar sarcoma in the right calf in the baseline. So this patient also has a metastatic disease in metastatic nodules in both the lungs. This patient underwent chemotherapy and there was a progressive disease seen with increase in the size of the lung lesions, also mild increase in metabolic activity. However, after immunotherapy, there was stable uptake and size of the calf lesion in the right leg. Also, the metastatic lung nodules were static, suggesting it to be a stable disease. Similarly, different response criteria have been proposed for lymphoma, out of which Duvalier score is the most commonly used response assessment. In this, FDG uptake is seen within the lymph node or extranodal sites. If there is no uptake in the nodal or extranodal sites, it is scored as 1. If the uptake is less than or equal to that of the mediastinal uptake, it is scored as 2. If the uptake is more than mediastinum but less than that of the liver, it is scored as 3. If the uptake is moderately more than that of the liver, it is scored as 4. And if there is significant high uptake as compared to that of the liver and there is appearance of new lesions, then it is scored as 5. And any area of uptake which was not related to lymphoma, they are scored or named as X. So these are some of the examples of different scores. So in this, the upper images are the baseline, and these are the follow-up. Below images are the post-treatment images. In this, in the first image, there is in the baseline study, lymphomatous disease in the seen in the bilateral cervical and retroperitoneal nodes. But in the post-treatment study, absolutely there is no any FDG uptake in either in above or below the diaphragm. So it suggesting it to be a score of 1, and there's complete metabolic response. In the second image, the residual disease is seen in the left axilla, and the uptake in the residual lymph node is less than that of the mediastinum and liver. So it is a score of 2. This is another left axillary lymph node lesion. Residual lesion in the left axilla with the FDG uptake is slightly more than mediastinum but less than liver. It is score of 3. In this fourth image, there is moderate increased FDG uptake in the right supraclavicular lymph node. So this is score of 4. And this in the fifth image, the residual lymph node mass is seen in the mediastinum, and the uptake is intense as compared to that of the liver, and it is scored as 5. So the patients with scores 1, 2, and 3 in nodal or extranodal sites with or without residual mass, then these are categorized as complete metabolic response. So patients with score 4 and 5 and who have visually reduced uptake as compared to the baseline study, so these are categorized as partial metabolic response. And patients with score 4 and 5 with no significant change in uptake when compared to that of the baseline, so here these are categorized with no metabolic response or stable disease. And patients with score 4 and 5 with increase in FDG uptake as compared to that of the baseline, or there is appearance of new FDG with lesions. So these are categorized as progressive metabolic disease. Another response criteria which is specifically used for head and neck imaging of PET-CT is Hopkins criteria. Here also, just like Duvalier score, the uptake pattern is compared with that of the uptake of the internal jugular vein and that of the liver. If the uptake at the treated site is less than that of internal jugular vein, as you can see in the in this lesion with the base of tongue, then it is categorized complete metabolic response. There apparently there is no any FDG uptake. Where this mild focal uptake is seen, which is more than internal jugular vein, but less than that of the liver, this is categorized likely complete metabolic response. When there is diffuse FDG uptake, which is more than that of internal jugular vein or liver, then it is categorized as likely post-treatment changes. Like in this study, there is mild uptake, diffuse uptake is seen in the oropharynx on left side, and there is focal uptake is seen at the treated side, which is more than that of the liver. It is likely to be a residual disease. Like in this, there is a focal uptake is seen in the base of tongue on right side, and when there is a focal intense FDG uptake, then like in this case in bilateral cervical lymph nodes, then it is categorized as residual tumor. Coming to imaging, coming to brain tumors, uh, that current treatment strategies for the brain tumor involve surgery, radiotherapy, chemotherapy, and other novel agents like immunotherapy. These effective treatment regimens of like especially radiation and surgery carry a risk of deleterious effects on the surrounding tissues, like resulting in radiation necrosis. The associated symptoms with radiation necrosis and tumor recurrence are similar in most of the times, and it is very difficult to identify the patient with these symptoms and to differentiate between the radiation necrosis or because of tumor is because of tumor recurrence by clinical examination alone. And also it is with the use of conventional imaging pattern, it is difficult to differentiate between these two treatment responses. So MRI provides an accurate morphologic information of the brain lesions, and PET-CT using different radio tracers evaluates the different metabolic pathways of the brain tumors. PET-CT and MRI should be often combined to evaluate the brain tumors in order to achieve high accuracy compared to a single imaging method. There are various different PET radio tracers are used for evaluating of the brain tumors, like FDG and different amino acids which are labeled with different radionuclides, which are used in routine practices. So out of these, FDG is the most common PET radiotracer which is available and which is most commonly used in oncology. The main concern of FDG in brain tumors imaging is because of the high FDG uptake in the normal brain parenchyma, which results in poor tumor to background ratio. And also FDG uptake is seen in the inflammatory and benign lesions. So other PET tracers which provide high tumor to background ratio, uh, that is, there is more uptake in the brain lesions and less uptake in the surrounding brain parenchyma. Such, if available, such radio tracers should be used. Some of the examples in the brain tumors. This is a case of a treated case of brain tumor. Hypodense area is seen in the para-hippocampal area. The FDG uptake shows intense FDG uptake is seen in the periphery of the lesion, suggesting it to be a disease recurrence. Another patient with another treated patients of brain tumor, FLAIR images show hyperintensity in the left temporal region. F-DOPA shows intense FDG, intense tracer uptake at the site, suggesting it to be tumor recurrence. This is the patient with suspected for tumor recurrence. This patient underwent both FDG PET-CT as well as fluorocholine PET-CT. As you can see in the FDG PET images, high FDG uptake is seen in the normal brain parenchyma, which is a physiological uptake. Because of this high FDG uptake, there is apparent less FDG uptake in the recurrent tumor, which hence it is very difficult to delineate in the FDG images. However, if you see the fluorocholine images, there is very less background uptake in the normal brain parenchyma, and then there is significant uptake is seen in the tumor, which makes it very easy to identify the tumors with the patient with the help of the amino acid tracers. Similarly, these are the cases with suspected with the recurrent brain tumors. Here also F-DOPA can is able to pick up the lesions in the right parietal as well as the frontal regions of the brain but as compared to FDG PET-CT, which is not able to pick up the lesions. In this study, the F-DOPA is compared with that of the F-choline, in which in this study, or in this case, the F-choline is found to be more sensitive to identify the lesion as compared to that of the F-DOPA. So in literature, there is a number of studies are available which compare the sensitivity and specificity of the different radio tracers which are available. And this is one of the meta-analysis which was published in 2021. And this study has shown that FDG PET has got a better specificity as compared to other amino acid tracers, whereas the amino acid tracers are found to be more sensitive as compared to that of the FDG. So none of the imaging or none of the traces available are superior to that of the other. So, as far as possible, combination of the tracer, whichever are available, should be used for accurate identification of the lesions for brain tumors. Also, it should be complemented or supplemented with MRI. So, at the end, to summarize, pseudoprogression can deprive the patient of effective ongoing treatment if not correctly identified. Response on follow-ups scan is key to identifying the pseudoprogression. Knowledge of the mechanism of action of treatment is important for identifying the pseudoprogression. PET can effectively supplement MRI to identify pseudoprogression of brain lesions. Amino acid tracers have lower uptake in the normal brain tissue than FDG PET. Hence, a combination of high sensitivity of amino acid PET and high specific FDG PET will yield a higher accuracy in identifying the brain lesions. Thank you. Thank you, sir.
Thank you, Dr. Ashish.
Thank you, sir.
I would request Dr. Senthil to first make his comments, and if he has got any questions for Dr. Ashish, please.
Thank you, sir. Very nice presentation, Ashish. You covered
Thank you, sir.
quite a bit of what we routinely see in practice. The first thing is pseudoprogression is not new. It's something that we've been seeing for ages. It's just that immunotherapy has made it very popular now. Everybody knows about pseudoprogression. The good old days, I'm sure Dr. Kishore will recollect, when you use a GnRH analog for patients with prostate cancer, or when you use tamoxifen for patients with breast cancer, you see a follow-up bone scan. You see that all the lesions are taking up more tracer and all of them seem to have increased, but you will find that the patients are not symptomatic for all of them. So for us, the most important thing that we look at when we see a scan that has progressed, especially during the time that we expect pseudoprogression. Now remember that pseudoprogression is not a common event. That's number one. Most of these progressions that we think are pseudoprogressions are actual progressions. The rough percentage of pseudoprogressions on immunotherapy is anywhere between 2 to 10%. Now, that's not a big number. And for most of these malignancies, the pseudoprogression rate is between 2 and 3%. We see very high pseudoprogressions in malignancies where there's a lot of immune modulation. For example, in patients with melanoma, in patients with kidney cancer, these are situations where we see more pseudoprogressions compared to certain other malignancies, for example, things like lung cancer. So whenever we see a scan that is showing features suggestive of progression, we always go back and ask our patients, are you feeling symptoms that can be related to this pseudoprogression or progression as is seen on the scan? Is your cough increased? Is your pain increased? Is the need for pain medications increasing? All of these things need to be checked. Now, if your patient says that my symptoms have worsened, then straight away you need to get to the next therapy. There's nothing like pseudoprogression and waiting for the next scan. While if you see features that Dr. Ashish has just now described, and your patient is not symptomatic for this progression, then it is okay to wait for 4 to 6 weeks, continue the same treatment, repeat the scan, and then see if it is pseudoprogression or true progression, and then get on to changing your therapy. So that's how we approach pseudoprogression. The most important thing is to look at your patient. No worsening of symptoms, some increase in the scans, hang on, continue the same treatment, repeat a scan later. While if you see that there is increase in the scan, there's increase in symptoms, there's no question of waiting, get on to the next treatment. That's the simplest and the easiest way to handle progression in clinical practice.
Excellent. I think you made a absolutely valid point. It's not the images we are treating the patients. And as you rightly said, that the pseudo progression is nothing new. I remember 20, 30 years back, when we were treating the patients of intracranial tuberculosis, histologically proven, CT and MR would show that on treatment the lesion is increased. But we were very sure because it was histologically proven case. So we would continue with the treatment and then again follow him after 3 months, and then we see that the lesion has significantly regressed or sometimes even disappeared. So at that time, this term was not used, but yes, it was already there. And now, as you said, immunotherapy has increased, made it more popular. Yeah. So yeah, I think that's about it. I mean, is there any patient who will come and trouble you that Dr. Ashish has written that the tumor has increased in size from 3 to 4 centimeter, and you assure him clinically, or does he insist that is something can be done, some other imaging can be done to further confirm it? Do you come across some such difficult patients?
Uh, yes, their patients are always sometimes skeptical when they see that the scan is showing worsening of disease and the doctor is saying, don't bother about that worsening, it is very likely to settle down. Unfortunately, there are no techniques that have been proven clearly to differentiate between pseudo progression and progression. The only way is to do a biopsy. During our initial days with immune checkpoint inhibitors, we used to do biopsies, and then most of these biopsies would show some inflammatory cells and nothing beyond that. Over time, we have learned to make our clinical judgments based on what we're seeing on the scan, what we're seeing in terms of symptoms, to decide whether this is likely to be pseudo progression or not, because you obviously have to repeat the scan to clearly show that this is not true progression. The other thing is that, more a practical tip. We don't do scans immediately in 4 to 6 weeks as the textbook would say, because it's not something that's very practical to do. So we usually schedule a scan in the next 2 to 3 months, not do it as early as the 4 weeks. That's number one. The place that we have the maximum problem in differentiating between pseudo progression and true progression is the brain, because it's not easy to go there and put a needle into the brain to check whether it's true progression or not. Patients sometimes are symptomatic, though we put them on some steroids and then the symptoms get better. And the other problem with the brain is that sometimes what you think is pseudo progression can actually be true progression, and they worsen very rapidly. So there are instances that we've been in a tight corner as far as the brain is concerned, but in most of the other systemic situations, we have been able to get away with our judgment and then do a scan a little later. Or if we are very, patients are very particular, or we are very particular about getting the true diagnosis, we do a biopsy early. So that's how practically in the clinic we approach somebody with a scan that's worsening, but patients are fine.
Right. So you seem to have some difficulty in the brain, for which fortunately Ashish has got an alternate fluorocholine. One example nicely he showed. That can help you. So I think that's good. So even in the difficult situation, sometimes we can help you.
Yeah, at least in Hyderabad, in our clinical scenario, like F-DOPA is available with us. So in such cases, we can do a combination of F-DOPA. Like first we can do an FDG. If that doesn't answer, then we can go ahead and do an F-DOPA. So at least we can provide you with some amino acid that is F-DOPA. Rest all tracers, it's very difficult logistically to make it available. So that is the reason.
Right, right. So in the difficult area, there seems to be some ray of hope and some light at the end of the tunnel. It's not very dark, so we are all optimistic about it. And I don't really see any questions from the audience. Right. So I think that's it. We are done. Any other final comments from anybody, Dr. Senthil or Dr. Ashish?
I think that's it.
Clinical correlation is paramount, I suppose.
Yeah.
Absolutely, absolutely. We are not treating the images, we are treating the patient. So patient first. I think that philosophy would always help us. And I think thanks everybody. Thank you, Dr. Senthil, for sparing your valuable time. I know how busy you are.
No,
Still,
nothing
you
like
readily agreed and spent. I told you that we will sharply finish it in 30 minutes, but it's already nearly 40 minutes.
No, that's all right.
Ashish, thank you very much for making a nice session.
Yeah.
So I think we'll close the session. Thanks, everybody.
Sure. Thank you. Bye-bye.
And I thank the Vijaya Diagnostic Management also. Thank you.